Welcome. I'm Dr. Neely Strickman from Texas Heart Institute, Baylor College of Medicine in Houston, Texas, USA. I would like to take the opportunity to again thank the organizers for again allowing me to participate in GIS and now 2022. Mr. Chairman, I'm going to talk about mechanical thrombectomy for DVT and pulmonary embolism. As you can see here outlined by the arrows, this is massive pulmonary embolism, a saddle embolus across the main pulmonary artery and into both the right and left pulmonary trunks. In DVT, the valves get clogged, and thus this prevents adequate flow of blood back towards the heart, thus causing large legs and is a propagation for pulmonary embolism. DVT and acute PE are two manifestations of the same disorder, venous thromboembolism. DVT of lower extremity is subdivided into either distal, the calf vein, or proximal, popliteal, femoral, or iliac vein thrombosis. And over 90% of cases of acute PE are due to emboli emanating from proximal and not distal. However, distal should be treated because it can cause PE. So I asked my referring physicians, what are the treatment options for DVT or submassive PE? 95% just heparin, IVC, filter, and lysis. I asked the same question then to the house officers and cardiology fellows. 90% mechanical thrombectomy or lysis, catheter lysis and half, and heparin alone, again, just half. The common etiologies for PE are cancer, hospitalization, and recent surgery with other disorders as well. And the primary goal is to prevent pulmonary embolism. I'd be remiss if I didn't mention phlegmatia ceruleus dolens, which is massive proximal iliofemoral venous thrombosis of the lower extremity, as seen here in the left leg. And this is a medical and or surgical emergency. If you're going to work in the venous system, you have to have some idea of the anatomy. Now, the veins that run all the way through the calf, even though they are deep, it is called the superficial femoral vein. You can't get rid of everything with thrombolysis alone. A lot of times the offending clot remains, and sometimes this may propagate despite using thrombolytic therapy. So the ultimate treatment choice is mechanical thrombectomy. The advantages are rapid clot removal, rapid resolution of the thrombosis, avoid the risk of massive systemic thrombolytics, the addition of local TPA as needed, a reduced intensive care unit stay, and lower cost. I'm going to speak about these 6 catheters as listed up here and show an angio for each of those. Now, the power post splay with the angiojet uses the Bernoulli effect. The outflow lumen is controlled by changing the control panel between thrombectomy and infusion. This has been changed now to the larger 8 French Zelante, which does the same thing as you can see here. This is an active control. Saline is spread out through the lumens. And then when you place it on thrombectomy, all the offending clot is removed. Now, this has gone out of favor because of the high degree of hemolysis and or renal failure that can be caused by this procedure. The angiovac or AlphaVac are also mechanical devices which use a deflecting 20 to 27 French system. Here we advance a funnel-shaped 20 to 27 French tip. As you can see here, by changing the direction, you are then able to pull the clot into the funnel. The handle is pulled, creating a controlled aspiration of the thrombus as seen here. Now you can do this manually as is shown here, or you can set it to be full vacuum with a 30 cc vacuum lock mechanism. Once the material is obtained in the funnel, it's then suctioned into the syringe barrel and then into the waste bag. The ECOS system is a rapid infusion system which has ultrasound acceleration for thrombolysis. Here, two ecosystems are placed in the right and left pulmonary artery, and TPA is administered through this system. The holes are 1 centimeter apart, and the smart part of the system is it only lets TPA to be released at these 1 centimeter segments and when it sees thrombus. If it doesn't feel that there's thrombus there, that hole does not release any of the drug you use. And you can see here the ultrasound acceleration improves the thrombus-laden TPA. The Inari system is fairly new. It has a core element. It collects and extracts venous clots all in one single session. The dilator is advanced, deploying the self-expanding funnel, which ensures maximum clot capture, as noted here. We advance the clot retriever beyond the thrombus, and then we pull back the nitinol coring element to retract all of the thrombus into the funnel and then subsequently into the thrombus collection bag. The Inari clot retriever, as shown here, shows all of the thrombus removed unfused in a common iliac and femoral vein. Now, the granddaddy of the flow retriever is the flow retriever, which is 27 French. And again, we use volume vacuum aspiration and all in a single session. First, the guide wire is advanced through the clot into the pulmonary artery. The retriever device is advanced, the dilator removed, and then we close the port, and by vacuum suction, we're able to take out all of the clot. The nice features now they have a cell saver, just like you would have in cardiopulmonary bypass, so that you don't exsanguinate the patient, because you could easily remove 500 to 600 cc's of blood during a single session. Here again, you see the line thrombus outlined in this diagram of both pulmonary arteries. The Penumbra lightning system comes in 7, 8, and now 12 French, and is a fairly similar. In the indigo, aspiration catheter is advanced into the clot, and it has a red and green flow switch which is turned on. And during the green phase, clot is actively removed. Sometimes the system can get occluded with thrombus, and then you would see a yellow light that is activated. And at this point, we have a choice to remove the system and flush it, or introduce a separate separator to macerate the thrombus. One other useful feature of this system is an auditory component, which clicks during active aspiration and then is silent when aspiration is complete. The Thrombolex Bashir catheter, it has a distal infusement segment that is 12 centimeters long, and you can put whatever fluids you want at multiple cross-sectional areas. In this Bashir catheter, each infusion catheter has multiple infusion ports with multiple holes to deliver the drug into various locations. Here, the catheter is then advanced into the thrombus, as shown here, goes over a guide wire. And the nice feature is, as you've crossed it, you can then release the red activator button and expand this infusion basket to allow for drug dispersion in multiple different areas. The basket can then be retracted after the infusion is complete, and as you can see, clot will then be removed. Here is the drug infusion, multiple small little ports. I'd be remiss if I didn't mention the May-Turner syndrome, which is the right common iliac artery overlapping and compressing the left common iliac vein, causing DVT. This is the most common cause of left-sided DVT. So who should get intervention? There's 1 million episodes of DVT per year, and 50% incidence of PE with proximal DVT if untreated, 20% which can be fatal. The iliac vein is the final common pathway to collaterals, thus we need to preserve the patency of the iliac vein. Likewise, if the common femoral vein is occluded, This should also be addressed at the same time. Here is my treatment algorithm. We first start with a venous Doppler. Then we choose anticoagulation. You may want to filter, lytic, or thrombectomy. And then you make your risk assessment as to catheter lysis, mechanical lysis, or unfractionated heparin. But how about in pulmonary embolism? Who should get intervention? Well, if it's a minor or non-massive PE, we can then use a systemic lytics. The patient is normotensive, there is no RV dysfunction, and no myocardial necrosis. The submassive PE, the patients are normotensive, but there is RV dysfunction and RV dilation by the echocardiogram. And in massive PE, the highest risk of all, the patients are hypotensive, and this is a cardiogenic shock situation. They may be pulseless, they may have been on inotropic support, bradycardic, and this looks like typical shock as you're getting no blood through the pulmonary artery. These patients are intubated throughout this course. Now, here is my algorithm for the treatment for pulmonary embolism. When seen in the emergency room or the diagnosis made, they're placed on heparin and a high-resolution CT scan is done. If this is normal, then no further treatment is needed for PE. But if the CT is abnormal, I would then continue the heparinization, do a two-dimensional echo to assess for PA and RV. If it's minor PE, you probably can continue the heparin, but if massive or submassive, that is when I go to direct therapy with mechanical thrombectomy. My take-home message is the following. Non-invasive duplex studies are the gateway to the diagnosis and treatment strategy for DVT, which leads to PE. Standard therapy with heparin or low molecular weight heparin remains adequate for the uncomplicated cases, but mechanical thrombectomy is needed for massive and submassive. I've shown you my algorithm and the interventional options. The key is to make the diagnosis early and communicate your findings with the admitting physician or the one who is going to make the appropriate therapeutic choices as shown in this short talk. I thank you again for allowing me to speak. Neely Strickman, MD from Baylor St. Luke's. Thank you.